Hello students, this is Dr. Nandhini, Assistant Professor from Department of Conservative Dentistry and Endodontics, Vinayaka Mission Shankaracharya's Dental College, and the topic for today's class is non-surgical endodontic retreatment. The contents are etiology and diagnosis of post-treatment disease, treatment planning, non-surgical endodontic treatment, coronal access cavity preparation, crown removal and removal of obturating material, and removal of separated instrument, management of canal impediments, perforation management, prognosis and conclusion. So what will be the cause of the post-treatment diseases? It is a persistent or reintroduced intraradicular microorganism, extraradicular infection, foreign body reaction and true cyst. The one in image depicts the persistent reintroduction of intraradicular microorganism, the second one is an extraradicular infection, and the third one is a foreign body reaction, and fourth one is an true cyst. These are all the main causes of retreatment. Definition for retreatment. According to American Association of Endodontics, it is a procedure to remove the root canal filling material from the tooth followed by cleaning, shaping and obturating the canals. Carr defined the endodontic retreatment procedure that is performed on the tooth previously and has been attempted to a definitive treatment and now requires a further treatment to ensure a successful result. What are the treatment options available for retreatment cases? First, we have to identify the cause of persistent diseases, and we should inform the patients regarding the opinions and options available for the treatment, and we have to make sure the patient have an exact time to decide the treatment plan. Occasionally, if the cause has not been identified, we also have to inform the patient, and we should avoid the trial and error methods in the patients. Second opinion in consulting with other dentists is also preferred in these cases. If it is a non-odontogenic cases, we have to check for the PDL and occlusal trauma that also mimics the retreatment cause. Patient with post-treatment diseases has 4 treatment options. One, we can go for no treatment, other one is extraction, and non-surgical retreatment option and surgical retreatment option. We can either go for surgical or non-surgical options, or we can do combined treatment. In non-surgical cases, the better success rate was evident, which is about 74 to 98%. It is also cost and time saving. In microsurgical techniques, success was improved, but it is just in second option. Surgical or non-surgical teeth treated with PA, which shows no difference in success rate. Each cause is potentially different, and retreatment should not be worsen the condition. So when we are treating the teeth with a PA of the lesion, we have a decision making tree which is regulated by RITs. First, we have to monitor and then decide. In monitoring cases, we are leaving the teeth as such, and we will not be treating the teeth, and we will be waiting over a period of time to see the prognosis or the condition which can be exaggerated. And in decision making, we have a no treatment cause, and next one we can go for a treatment one. In treatment, we have an extraction option and other one is a retreatment option. If we are going for the retreatment, we have 2 modes of retreatment. One is surgery and other one is non-surgical retreatment. Here we are going to see the non-surgical endodontic retreatment. In non-surgical endodontic retreatment, what we have to do first is to regain the access in the periapical area, and next we have to remove all the coronal obstructions. Retreatment causes, if they are placing a crown or the coronal area, if there is any restoration, we have to remove that, which is known as a coronal disassembly. The previous restoration or crown, which has to be partly or fully removed. If access is difficult via crown, we can remove the crown, or we can use in burrs crown removers and bridge remover instruments. Next method is to gain access to the root canal in the coronal disassembly area. These are the elevators which helps in crown removal, and this one is in Vamsky. The other one is we can use a manual sliding hammer or a pneumatic crown removers. This is in coronoflex instrument showed in the picture, and it uses in compressed air of ultra short impulses at the tip, which dislodges the cement and uses a parachute technique where the metallic wire loops around the embrasure connected to a rod. A tip is placed on activated delivery micropulses and break cement bonds. Next one, if we are placing a post and core, when we have to remove it, and we have 4 factor influences of post and core. First, we have to know about an operator judgment, Training is actually necessary before removing or thinking about the process of removing. Experience and utilizes the better knowledge and technique. These are the Gonon's universal post removal system. The first diagram depicts picture which has a complete set, and the second diagram depicts the method which we can remove using the trephines and burrs. The other method to remove post is to apply a methyl blue dye, piezo drill and a largo burr, gyro tips which helps in heat generation to soften the fiber reinforced core, and fluted zone of drills were used in FRC material. Above the fluted zone, plasma bonded silica carbide uses to reduce the friction in the material. If you are using a ceramic or zirconia post, it is difficult to remove. So, in such cases, removal option is actually considered as an worst opinion. Complications of post removal, which leads to perforation, excess removal of dentin and fracture of post. And other one is microfracture during a post removal, which lead to vertical root fracture. Post removal is difficulty. Surgery would be a second option. Perforation, if we have caused a perforation and we have to move for any other options which is available next to the retreatment cause. Small segment posts are actually difficult to remove. Identifying the cause of missed canals. If patient comes to the department with continuous pain even after the treatment, and when we are seeing an X-rays, the treatment which has previously done was perfect, but the patient complains of continuous pain, we have to check for the missed canals. We have to think whether we have missed any canals. So, missed canals can be found out by any of this method using a microscopic method, root dentin map, trans illumination method, champagne bubble test, and eccentrically placed orifices. Pulp canal obliteration, which is also known as in PCO, and up to 25% of traumatized anterior teeth we can see the PCO conditions. It is in high difficult category, and there are 20% chance of failure when we are treating a obliterated pulp canal. Next, we have to do access to the periapical area. This is the main cause. When we have not done it properly, it will lead to further infection. For this, we have to do the coronaradicular obstruction should be removed. Access to apical area, we have to remove the previous root filling material. Various materials such as GP, carrier based GP, paste, BC sealers, and occasionally silver cones were used. Obtain information from the previous clinician. If no information is recorded, and do the case with extreme cause. Gutta perca removal. Gutta perca is usually easy to remove, and we can remove it by heat and solvent methods and instrument. We can go for a multiple techniques. We have to remove the gutta perca, and the GP is heated and it is softened near the orifices. Heating and cooling to remove the coronal GP. GG drill in the cervicular portion were used. C+ files were used to bypass the GP. Poorly obturated GP were removed easily. These are the gutta perca solvents. Well condensed GP solvents we have to remove with chloroform, eucalyptus, turpentine, xylene, orange peel oil, but chloroform is a faster dissolution, xylene and halothane is a slow dissolution. But chloroform is carcinogenic and halothane is toxic, so these were not used nowadays. Rotary instruments for removal of GP. It is easier and a faster method to remove the GP, and we have a pro taper retreatment kit which has a D1, D2, D3 tips and which has a millimeter of 16, 18, 22, which has a taper of 9, 8 and 7, and they have a passive fit and they have an RPM around 800 to 1200 RPM, and the blades were designed to push the softened GP coronally. Techniques to remove gutta perca. We can use H files, solvents, use of heated spreaders, GPX remover, pro taper, pre-treatment files, piezo reamers, GG drills. Next one is in silver point removal. Silver point were not actually used nowadays, but in the olden days silver points were preferred as an obturating material. So, silver points corrodes easily and it leads to lack of apical seal. Removal of core material around cones, solvent to remove the cements and grasp the plier. Ultrasonic vibration uses indirectly, and we can use H files to remove it. Instrument retrieval kits can be used, cleaning and shaping in a crown down manner. A removal of separated instrument. In that we have to see the cause of separation instrument, prognosis of the treatment, removal technique, bypassing of instrument, surgical removal and prevention. Separated instrument block the access to the apical portion. Various types of instrument were used, which is files, GG tips, hand instruments, broaches, reamers, whatever it can be. Evident after removal of a previous GP, we have to check for the next ray. Night eye instrument fracture is in the range of 0.4 to 23%. Causes of instrument separation: improper usage, limitation in the physical property, inadequate access, root canal anatomy, manufacturing defects. Too much apical pressure with an engine drive and handpiece, instrument deflects, and increased frictional pressure causes an overstress and lead to fracture. In dry canals, frictional resistance were high. Debris on the file to be periapically removed and cleaned constantly. Inadequate access and excess forces lead to more fracture. Abrupt curvature and ledges also lead to fracture. So next, what will be the prognosis of the teeth with separated instrument? Instrument separation does not mean surgery or extraction. The prognosis depends on what stage of cleaning and shaping the instruments are separated. Previous pulp and periapical status of the teeth to be noted. Instrument can be removed or bypassed. Later stages of cleaning and shaping, the prognosis will be better. If it is unable to remove, the necrotic debris and apical periodontitis will be closely monitored. So then we can go for an options of extractions or any other surgical management. Factor influencing removal. So we have to check for the location of an instrument and the straight portion of the canal. It will be easier. If it is an apical to the curvature, it will be difficult to remove. If it is unable to bypass, we can go for surgery or extraction. Coronaradicular axis lead to perforation. Thin roots, deep concavities, type of instrument, whether it is an nickel titanium or stainless steel instrument, and skill of the operator. These are the main methods to check for the instrument removal. The first M stands for metal. We have to check whether what type of metal were used. It is a nickel titanium or stainless steel method. Next one is microscope, which helps in visualization. Next is anatomy. So we should know the anatomy of the canal before moving to the next step. We have to know the complete anatomy, whether it has a single canal or a two canal, or whether the canal is located, a single canal is located in the straight portion or it is diverging near the apical portion. Next, the position of the instrument breakage, whether it is in the cervical region, middle third, or in the apical third of the root, and we should have skill whether to remove or not to remove, and in which way we can remove the instrument. If the instrument is loose fitting and projecting in the chamber, we can grasp the instrument with an hemostat, pull out with a slight anti-clockwise rotation. This will lead to the instrument removal from the broken area. Next one is in Maceran kit, and this helps in removal of fracture instrument and straight portion of the canal. Trifine drills and tubular extractors were used, which is about 1.2 and 1.5 mm, to create a space in the root canal around the coronal 2 mm of the fractured area. Extraction is then locked over and the instrument is removed. This one is IRS system. It is an instrument retrieval system. We have a microtube and wedges of various sizes here, and it is designed to work deep down the canal. Coronal 2 mm of a fracture instrument is exposed and a suitable microtube is inserted over it, and inserted wedges is inserted to the microtube, and the fractured instrument is engaged and secured by turning the insert wedges in a counterclockwise direction, and the fractured instrument is lifted out with the assembly. The picture depicts IRS instrument which comprise of microtubes and an internal screw which engages mechanically and removes the intracranial obstructions. Canal finder system. It consists of handpiece and exclusively designed files which provides a vertical movements and with an amplitude of 1 to 2 mm. Fluid engages the fracture files and vertical vibration helps in removing and loosening the instrument. If the file is used aggressively, it leads to perforation. These two were endo rescue kits, and other one is in Cancella kits, and here in endo rescue kits we have first 3 instruments, and the first one is in GG drill number 3, and next one is in centering drill, and this one is in Trifine, which have a same internal diameter. The internal diameter of Trifine is 0.5 mm, and the second, this picture is in complete kit, and this one is in Messinger Trifine bar, and this one is an SIR, separated instrument retrieval system, and rodent extractor. If the separated instrument is deeper inside the canal, the coronal radicular axis has to be modified using a GG drill or using a light speed ultrasonic systems, and we have to create a staging platform. Ultrasonic is kept between the instrument and the canal wall, and it is vibrated around in counterclockwise direction, and energy is applied over the area and which helps to loosen and to grasp is removed. These were canal braiding systems. Here H files were used over the lateral areas, and these files engages the broken instrument at the tip edge of the area or mid end of the fractured instrument, and the canal were twisted together, and which helps to grasp the instrument over here and which can be pulled out very easily if it was loosely packed. This one is an hypodermic needle and glue system. Here a needle were used. In the tip of the needle we are using a cyanoacrylate material which is in contact cement, which is kept under the broken silver points or the fractured files, and this cyanoacrylate locks the instrument with the needle, and with an anti-clockwise rotation we can rotate and we can remove the instrument. Either it can be a silver points or a files. Wire and loop method. Here we are using wire over the thing. A needle is placed over here and a H file were used over here, and this helps in grasping the instrument, and it is rotated in an anti-clockwise direction and the instrument is removed. Next one is loop method. A loop is used over and engaged with the instrument, and these were rotated in an anti-clockwise direction and the instrument were loosened, and it can be removed directly or using then other sort of pliers. What will be the prognosis of retreatment? Proper diagnosis and retreatment should be carefully performed, which lead to a successful conditions. If there is a case with no apical periodontitis, the success rate is around 92 to 98%. If there is a persistent apical periodontitis, the success rate is actually decreased, which is about 75 to 86%. If there is no healing is observed, we have to go for observation, surgery, intentional reimplantation and extraction methods. So here I conclude, we should know about the detailed causes of the failure, and possible complications should be noted over a period of time, and we have to give a patient to decide whether they have to undergo the treatment or not to undergo the treatment. James L. Gutman have informed, when choosing the non-surgical endodontic retreatment, careful assessment and treatment planning with each cases are the cornerstone to success. These are the references. Thank you students for watching this video.